Hello, everyone. My name is Fernando Lopez-Rios. I am a pathologist working at Hospital Universitario 12 de Octubre in Madrid, Spain. So I'm going to talk to you today about the landscape of biomarker testing for patients with non-small cell lung cancer. I think this issue can be easily addressed by trying to answer these two questions. The first one would be, what is the best way to deliver biomarker information? And the second one would be, what are the clinical practice gaps? So let's start by trying to answer the first question. What is the best way to deliver biomarker information? Next generation sequencing is the best way to achieve comprehensive testing, as you can see in the figure, because the number and complexity of the actionable findings that we need to investigate in patients with non-small cell lung cancer is currently too large to use single gene approaches. We need to study mutations, EGFR mutations, of course. Now we need to be very precise and try to identify exon 20 insertions in the EGFR gene. We also need to study KRAS mutations, particularly KRAS G12C are now actionable. Of course, MET exon 14 mutations, BRAF mutations as well. And it's also, as you know, very relevant for patients with non-small cell lung cancer to try to identify actionable fusions. So we need to study ALK fusions, ROS1 fusions, RET fusions, and of course, NTRK fusions. We also need to be aware of the different frequencies in the different regions of the world to try to come up with efficient biomarker testing workflows. So the recommended option, as you can see there, option A would be to run PD-L1 immunohistochemistry and then upfront NGS. But of course, sometimes this is not possible. So we end up doing PD-L1 and single gene approaches for all those biomarkers. We need to always keep in mind that if the result is negative, or if we need a full variant annotation, we need to consider broader gene testing by next generation sequencing. If we look at the clinical side of things, we need to emphasize that testing needs to be as comprehensive as possible. As you can see there, if patients receive incomplete testing, overall survival is only 11 months versus 22 months, 2 times that for patients who have received comprehensive testing. So we need to be very thorough, but also we need to be fast. As you can see there on the right, if the results are not ready before the beginning of first-line therapy, overall survival is only 6 months versus 4 times that, more than 2 years, more than 24 months when the results are ready before first-line therapy. So we need to keep in mind that comprehensive genomic profiling doesn't mean that our turnaround time increases to the point where the results are not ready before the beginning of first-line therapy. This brings me to the topic of the clinical practice gaps. So this is the second question that we need to try to answer. So here I wanted to share with you the results of a survey with 500,000 patients with advanced non-small cell lung cancer in the United States. And as you can see there, almost 50% of those patients were lost to precision oncology because of factors associated with biomarker test results. This is a very complex matter, but I think it can be easily summarized using those 4 words. So first, we have issues with biospecimen collection, because maybe the tissue was insufficient or the tumor content was overestimated, etc. Then we have problems with the assays. Sometimes the tests were not ordered, or the results were inconclusive, etc. And of course, we have the issue of the turnaround time and cost is always something that we need to address when organizing comprehensive genomic profiling. So in conclusion, if we look at the journey of a patient with non-small cell lung cancer from a biomarker standpoint, regardless of stage, it's important to highlight that all of those patients might need comprehensive genomic profiling. We can use tissue, but also plasma. We should not forget about liquid biopsies. And because of this very complex scenario now with adjuvant and neoadjuvant opportunities, we might have to repeat some of these efforts over time. And this is, of course, very challenging from a workflow perspective. And that's why effective communication here is key, both within the pathology department, within the lab, and also with our clinical colleagues to make sure that all of our patients have this information ready when decisions need to be made in terms of treatment and follow-up. So with this in mind, I wanted to thank everyone in the team here back home for all the efforts trying to make sure that all of our patients with non-small cell lung cancer have as much information as possible to try to find actionable findings for the treatment. Thank you.